Thank you for joining us today. My name is Jeanette Goria, but I'm the Health Information Specialist with Brain Tumor Foundation of Canada. We are very excited to offer our 5th webinar of the 2013 Healthcare Professionals Webinar Series with Hellen Jung. Before I introduce Hellen, I would like to get an idea of who is online with us today. So I'm going to launch a poll here for everybody. And if you could please let us know, for those of you who are healthcare professionals, if you could tell me if you're a physician, a nurse, or a social worker, an occupational therapist or physiotherapist, or other allied healthcare professional. And I'll just wait a moment to allow everybody to answer that question. Perfect. So here we have about 80% of you are nurses, and 7% of you are social workers, and 13% are allied healthcare professionals. That's great. And my second poll question, which is the first question I should have included first, is: are you a healthcare professional, a volunteer, a family member or friend, a patient or survivor, or other? I'll give you a moment as well to answer that question. And it looks like that 100% of you are healthcare professionals. Perfect. So we're going to get started now, and I'll introduce Hellen. Hellen has been an oncology nurse for 20 years and enjoys her work caring for cancer patients immensely. Out of the Tom Baker Cancer Center, she is working on quality improvement measures for individuals living with a diagnosis of brain metastases. I would like to also add that Hellen is the recipient of the 2011 Brain Tumor Foundation of Canada Cano Award for Excellence in Neuro-Oncology Nursing for this particular presentation and topic, Understanding Brain Metastases, an Overview of Treatment Options and Care Guidelines. So welcome, Hellen, and I'd like to turn it over to you now.
Thank you very much for the introduction, Jeanette, and a warm welcome to everyone who is online. I've never presented via webinar format before, and it is a little bit foreign for me to not see the faces of who I'm speaking to. But I do have a few poll questions that I would like to ask at various points during the presentation that will give me a sense of your background and hopefully also help keep you engaged as we move through. Sorry, I'm just trying to advance the slide here.
If you just click your cursor, Hellen, sometimes it'll
yeah.
just, there
okay.
you go, perfect.
So the objectives of this presentation are outlined here, but the main hope is that the information presented will increase your understanding of individuals who are affected by a brain metastases diagnosis and how we all, as care providers or loved ones, can support them through the journey that lies ahead of them. And so I will weave a few patient cases through the presentation also to get you thinking maybe a little bit more about what kind of impact this diagnosis can have on individuals and their loved ones. So I'm ready for the first poll question.
Sure. So how much experience have you had caring for an individual affected by metastatic brain cancer? Please select one. Is your experience a lot, some, or none? I'll give everybody just a moment to answer that. Okay. And it looks like it's a good mix, Hellen. We've got 26% that said a lot, 63% that said some, and 11% that said none.
Okay, well, great. That gives me an idea of where everybody's coming from as far as backgrounds. So by way of introduction, I'd like to introduce you to a patient by the name of John. John is 51 years old and previously healthy. He does have a smoking history. And one day at work, he suddenly noticed a problem using his right hand, which then spread to the use of his right arm. And then eventually, over the course of about a week, he had some problems with coordination of his left leg as well. And obviously, this impacted his work and his ability to drive. And so he presented to an emergency room where they did a CAT scan of his head, and they found that he had 3 brain lesions. He was then admitted to the hospital for an expedited workup to find out where this cancer came from. And when they did a CT of his chest, they found lots of indications that suggested that he had some kind of a lung cancer. So ultimately, a biopsy was arranged of his right upper lobe lesion, and he was given the diagnosis of non-small cell lung cancer, and in fact was given the information that he had stage 4 lung cancer, and this all started with presentation of neurological symptoms. So brain metastases is the most common intracranial tumor in adult cancer patients, and it's about 4 to 5 times more common than primary brain tumors. It's estimated that up to 40% of cancer patients will develop brain metastases over the course of their cancer journey. And the incidence of brain metastases is on the rise due to a few reasons. We are improving our systemic treatments for patients, and so individuals are living longer with cancer. As the age of our population increases, the incidence of brain metastases increases, and also over the years we've had improved diagnostic imaging capabilities that are more sensitive at picking up these brain lesions. So by definition, brain metastases are metastatic lesions that have spread to the brain tissue from a primary cancer in another site. And they can be detected in a variety of scenarios. Sometimes they present themselves without any knowledge of a previous cancer diagnosis. So such as John's case, where he presented with abnormal neurological symptoms, and this led up to being diagnosed with cancer. Sometimes they are detected during a staging workup for a new cancer diagnosis, and oftentimes they arise when cancer progresses or it recurs. From left to right here are the most common to least common primary cancer sources of brain metastases. And lung cancer and melanoma, multiple lesions are more common with those types of primary cancers. And with breast, kidney, and colorectal cancer, it's more common to have single lesions. But of course, these are not hard and true all the time. About 80% of metastatic brain lesions are found in the cerebral hemispheres of the left and right frontal, parietal, occipital, and temporal lobes. And less commonly, they are found in the cerebellum and the brainstem. So how do these cancer cells get to the brain from their original site? The cancer cells escape from the primary tumor site, and then they invade surrounding tissue and enter into the bloodstream or lymphatics. Then it is through the lymphatics that the cancer cells are further disseminated to secondary sites where they grow or proliferate. In cranial circulation, metastatic cells tend to accumulate in gray or white matter junction at what is called watershed zones. And watershed zones in the body are locations that are fed by the distal branches of 2 large arteries. So in the brain, this would be areas that are perfused by both the anterior and middle cerebral arteries. And where the tumor cell deposits depends on a variety of factors, such as how big the cell is, and also cells tend to go to surface receptors that have recognition on the target organ. And ultimately, the metastatic process is completed when the cells leave the capillary system and then they enter the brain tissue. Not all brain metastases cause symptoms. Occasionally, they are detected in CAT scans of patients incidentally when they are ordered for other medical reasons. However, the majority of brain metastases are accompanied by a variety of symptoms, and the most common one being headache, followed by the other ones here that are listed. And the type of symptom that an individual can present with, of course, depends on the location of where these lesions are in the brain. So brain metastases are most commonly diagnosed by diagnostic imaging, usually with a CAT scan. And here you can see a non-enhanced scan of a solitary metastases compared to an enhanced scan of the same lesion and how much clearer the enhanced picture is. And so for that reason, an enhanced CT is always preferred when ruling out brain metastases. It just gives us a better picture. Here is a CAT scan image where there are multiple lesions that can be seen. And here are some MRI cuts that show brain metastases. And for brain metastases, an MRI is a much more sensitive test than a CT and can detect much smaller lesions, and the picture is generally clearer. And again, a different view of an MRI that has multiple lesions that you can see. Despite a CT or an MRI reporting findings of brain metastases, it is always important to consider a tissue biopsy in addition as a next step, especially in a few scenarios. It's especially important if the individual has no known history of cancer, or they may have cancer in only one location of their body and there's no evidence of any other metastatic disease anywhere else. As with other medical problems, you would want to be sure of the diagnosis before thinking about treatment. And in some scenarios, although lesions look to be metastatic on imaging, without a biopsy, the diagnosis cannot be conclusive. And so the medical team would decide about the merits of needing a biopsy on an individual basis, and of course would choose the least invasive site, whether it would be a primary site or another metastatic site to biopsy, and the brain, of course, being quite an invasive site to get tissue from. So here is another case of Jane. Jane is 30 years old, and she was diagnosed with breast cancer of her left breast about 5 years ago. She had surgery. She had a lumpectomy and a lymph node dissection, and then she went on to receive chemotherapy. However, over the last 2 years, she's had several episodes of recurrence. And she was aware that she had metastatic disease throughout her body, and she was treated with more chemotherapy and hormone therapy. She had been experiencing for about 2 months headache and nausea, and she thought perhaps she was even having mini seizures where she was sort of losing awareness for a couple of minutes at a time. And she also eventually ended up in an emergency room where a CAT scan diagnosed her with brain metastases. She had also 3 lesions, and the largest was less than 2 centimeters. So thinking a little bit about this scenario, it's important to think about the implications of brain metastases. Regardless of where the individual is at in his or her cancer journey, and regardless of what type of cancer he or she has, receiving a diagnosis of metastatic brain lesions is devastating. It is accompanied by news that the cancer is no longer curable, that over time they will be expected to experience worsening functional decline, and of course this would imply the loss of independence. Perhaps they're already experiencing that, or at some point in the future they will not be able to be as independent as they want to be. And in the case of Jane, she had just started back at university and was halfway through taking an early childhood education degree. And given this news of a brain metastasis diagnosis, along with finding out that she has a much shorter life expectancy than she thought, really caused her to make decisions such as dropping out of her studies. This is a serious diagnosis that requires urgent medical attention, or occasionally, depending on how the patient is doing clinically, emergent medical intervention may be required as well to manage symptoms from severe cerebral edema. And once the individual is stable neurologically, a referral to radiation oncology is appropriate to explore oncology treatment options. Unfortunately, brain metastases is not a curable condition, And the treatment goals are to improve symptoms, to improve or maintain functional status, provide control of disease in the brain, and hopefully extend survival. So it's really about quality of life and hopefully quantity of life. Unfortunately, the prognosis associated with brain metastases is very grim. When looking at estimated median survival without any treatment, it's about a month. If the patient is on steroids alone, then about 2 to 3 months. And then with treatment, so some kind of combination of radiation treatment plus or minus steroids, the estimated median survival is 4 to 6 months. So not long survival. So I'm ready for poll question number 2, please.
Sounds good, Helen. I'll launch that for you right now. So what factors do you think influence prognosis for a patient who has brain metastases? If you could please select one, either patient's functional status, type of cancer, response to steroids, or all of the above. And it looks like everybody's answered, and 100% say all of the above, Helen.
Good. That's when you're not sure, always pick all of the above. When we look at this prognostic tool, in 1997, the Radiation Therapy Oncology Group, or RTOG, developed a prognostic index for patients with brain metastases using a type of statistical analysis called Recursive Partitioning Analysis, or RPA. And what they did was they examined the characteristics of about 1,200 patients in a large database from 3 clinical trials between 1979 and 1993. And all of these patients already had treatment, whole brain radiation treatment. So when they looked at this, they teased out characteristics that had a significant impact on prognosis in this population. And they were able to find 3 key factors. One of them is Karnofsky Performance Scale, or KPS, whether it was above or below 70, whether or not disease was controlled or not controlled, and the age of the patient, either over or under 65. And based on this, they developed 3 classes of patients in terms of prognostic indicators. And what they found was that the patients in RPA Class 1 had the best median survival. They would their median survival would be around 7 months, and those in RPA Class 2 had a median survival of 4.2 months, and those in RPA Class 3 only 2.3 months. And you can see, though, that KPS alone is a major prognostic characteristic, because as soon as a patient drops to less than a KPS of 70, this automatically puts them into a Class 3. Now, I'm going to just in case some of you are not familiar with what KPS is or what a KPS of 70 is, to have a KPS of 70, the individual has to be able to care for themselves, even if they're not able to do any normal activity or work. So they have to be able to look after their own care needs independently. As soon as they require even occasional assistance from others, they are below a KPS of 70. So when you're thinking about people living with brain metastases and the symptoms associated with it, it's not surprising to see or to see that a majority of patients don't have a KPS of 70 or higher. This is a very busy slide, but I thought it was important to put on here because it's, again, looking at prognostic indicators for people with brain metastases. In 2010, Sperduto and colleagues published in the International Journal of Radiation Oncology and Biology Physics a further retrospective analysis, again, trying to look at for significant prognostic factors according to the type of primary cancer. And what they reported was that the prognosis for brain metastases differed according to the type of primary cancer, and that prognostic factors were not the same for every type of cancer. So, for example, in lung cancer, age, KPS, the presence of extracranial metastases, and the number of brain mets were significant to predict prognosis. But for example, with breast cancer and GI cancers, only Prognostic performance scale was a significant prognostic factor. So the bottom line is not all cancer types have the same prognosis once it has spread to the brain. There are many types of therapies that play a role in the treatment of brain metastases, and many of them go hand in hand and not necessarily in a predictable linear pathway. Could we have poll question number 3, please?
Hi, Helen. Sure thing. So what is the best initial treatment for symptomatic brain metastases? Please select one, either chemotherapy, radiation therapy, steroids, surgery, or none of the above. Give everybody a moment. And we have here 17% said chemo, 25% said radiation, 50% said steroids, 8% said surgery.
Thank you.
You're welcome.
So the correct answer is steroids. And so one treatment option for brain metastases is that of steroids. And it is the main, it's a useful initial and ongoing treatment to treat cerebral edema and associated symptoms. And it really is the first thing that should be tried. The steroid of choice is dexamethasone, and it's effective because it stabilizes the blood-brain barrier, and it does this by upregulating angiotensin 1, and it regulates VEGF, which promotes permeability of astrocytes and parasites. So it has a really good effect on the blood-brain barrier, and it is preferred over prednisone because it has a longer half-life, and because it has a lower mineralocorticoid activity, it reduces potential for fluid retention that prednisone can have. Because of steroids' effectiveness in decreasing intracranial pressure, neurological symptoms from the use of dexamethasone can be seen in about 75% of patients just with the use of steroids alone. And there can be a regulation of the intracranial fluid shift in about 6 hours, so it's fairly fast acting. And if you were to do an MRI on these individuals, you can detect decreased edema in 48 to 72 hours. Despite that, however, noticeable clinical improvement may take several days or possibly even a week. And if steroids are not helping, additional interventions can be considered that are more emergent or critical interventions, including things like mannitol, adding other medications like calcium channel blockers, perhaps using analgesia and sedation. Despite the fact that they're very effective with managing cerebral edema, there are some downsides to using steroids, and I think most nurses are familiar with these adverse effects. And so even though it's a very effective treatment, it has to be administered carefully and ideally for short term. Once it's started, dexamethasone is continued usually for at least several weeks, and once subsequent treatment is completed, they are, the goal is to taper them. Some individuals are on steroids for much longer, and perhaps for several months or perhaps even the rest of their life if it is necessary to manage ongoing symptoms from cerebral edema. But the role of long-term use is to control symptoms, and steroids do not delay the progression of cancer. In 2009, a systematic review and evidence-based practice guideline was published in the Journal of Neuro-Oncology that was looking at steroids and the use in brain metastases. And an initial review of the literature demonstrated a significant variability in practice with a lack of well-controlled studies that are looking at this issue. And the authors remarked that it is interesting that so many authors seem to assume steroids are a mainstay of treatment for patients with brain mets, despite the relative lack of detailed information to guide the specific therapy. And they were only able to find 2 studies that even met the eligibility criteria for review. And as far as what level 3 evidence is opinions of respected authorities that are based on clinical experience, descriptive studies, or reports of expert committees, so peer-reviewed. Now, how they summarized this, or what they concluded, was that if patients are asymptomatic from their brain metastases, there's insufficient evidence to suggest the use of steroids at all. If patients are having mild symptoms, there is level 3 evidence to suggest that they're good to temporarily relieve symptoms. And a starting dose that they recommend is about 4 to 8 milligrams a day. If there are moderate to severe symptoms, then there's level 3 evidence to support the use of steroids, and a suggested dose would be about 16 milligrams a day. And the author said that a taper should be over at least 2 weeks minimum and individualized. Another treatment option for brain metastases is surgery. And it may be surprising that we are talking about surgery in a situation of metastatic disease to the brain, particularly when we've already talked about this scenario being an incurable one. So it sounds like surgery seems to be quite an aggressive measure. However, it is important to at least consider neurosurgery consultation, especially if the lesions are between the size of 0.5 centimeters and 3 centimeters. Now, these are rough guidelines, but if they're less than 0.5 centimeters, then they're too small to resect, and greater than 3 centimeters, they may be getting upwards of the criteria for resection. As far as number of lesions, even though there are multiple lesions, they may still be resectable, especially if it's through a single craniotomy site. And sometimes in multiple lesions, neurosurgeons will still try to get some of that tumor out for tissue diagnosis. Of course, it's dependent on the location, and the neurosurgeon would have to determine whether there would be risk to surrounding structures and risk for neurological deficits. But overall, surgery is preferable over radiation treatment for lesions that have a lot of edema, and we'll talk about that a little bit later. And when you think that about 37 to 50% of patients will present with a single lesion, the option of resection should always be on the table. So what does the evidence say about surgery? There is evidence to suggest that a combination of surgery with post-operative radiation treatment is of value, especially of patients that have a good performance status and limited disease outside of the brain. There is a lack of evidence to support surgery if patients are not doing well as far as performance status, if they have advanced or uncontrolled systemic disease, or if they have multiple brain metastases. For decades, whole brain radiation treatment has been the standard treatment for brain mets. And in whole brain radiation, the whole brain is irradiated, and there's no attempt to target only the metastatic lesions. And the rationale for this, for treating outside of the known tumor bed, is to treat potential microscopic disease and hopefully prevent future widely disseminated disease throughout the brain. Primary tumor types vary in their responsiveness to whole brain radiotherapy. Small cell lung cancer, leukemia, lymphoma, germ cell tumors are highly responsive. Breast cancer and non-small cell lung cancer are considered moderately responsive, and melanoma, renal cell, and sarcoma are considered less responsive to whole brain radiation treatment. Because whole brain radiation treatment will always cause some degree of cerebral swelling, it is not advisable to start this in patients who have not at least had some partial response to steroids. For severely symptomatic patients, they should be on steroids for at least 72 hours to assess improvement, and if there is none, the argument could be made that starting whole brain radiation treatment will make them worse and potentially shorten their life. Or if patients are on very high doses of steroids already, if we add radiation treatment, there is not much room to further increase their steroids to manage any additional edema that the RT will cause. So unfortunately, whole brain radiation treatment is not an immediate fix. As with all radiation treatment, it may take weeks for noticeable effect and upwards of 4 weeks for optimal effect. If individuals are not improving on steroids and their clinical condition is deteriorating, that is the precise scenario where adding whole brain RT could be fatal. There are many dose fractionations of whole brain radiotherapy in practice, and depending on the technology available in radiation department and the preference and practice patterns of the radiation oncologist, some whole brain radiation treatments are done with just a clinical markup. So an X-ray is taken of the patient's skull, making sure the whole brain is encompassed in the treatment field, and there's no other treatment planning steps involved before the radiation can start. For brain lesions that are in hard-to-target areas, such as behind the orbits or the temporal regions, or maybe the base of the skull, a mask may be made to help immobilize, and then the planning would require a planning CT scan so that the radiation oncology team can ensure these lesions are encompassed. So here's an example of what a pre-treatment X-ray for a clinical markup would look like. This is taken while the patient is positioned on the radiation treatment bed, and once the radiation oncologist reviews the film and determines that, yes, the whole brain is in this treatment field, the patient can have the radiation started. Here's an example of what a mask may look like that would be made for the patient if they felt that they would need more elaborate planning, and it would aid in accurate, reproducible immobilization for the planning CT scan and also for the subsequent treatments. Just for interest's sake, I thought I'd put in a little picture here of the COBALT machine that we do our whole brain radiation on at the Tom Baker Cancer Center. I'm told it's old technology, though, so we may not have it for much longer. Fatigue is always an expected side effect of RT to any site, but with whole brain radiation, this fatigue is more pronounced and can be even described as mild to severe lethargy, which can last months or longer. There can be increased cerebral swelling as a side effect, and so patients may have some potential symptoms with this, either development or worsening headache, nausea, vomiting, or visual disturbances. They will have skin changes. Their scalp will become more pink, like a sunburn, a mild sunburn, and they will lose all of their hair. And then something that we talk about are late effects of whole brain RT, and those are usually irreversible and progressive, and those happen somewhere 6 months to a year down the road. And these symptoms can range from mild memory loss to mild dementia and are thought to be a result of vascular injury that causes prominent white matter damage. And most patients, however, don't live long enough post-whole brain radiation to experience these late effects. So just a summary of some of the data in randomized controlled studies that are looking at whole brain radiation. They have found that there is no difference in survival benefit between the dose and fractionations that are prescribed. However, higher dose per fraction does have more risk of causing those cognitive changes later down the road, as I just mentioned. Complete response and partial response of whole brain radiation is about 60%. How much of that might be attributable to the steroids, we don't know. But even with complete response, we know that these lesions will, over time, grow again, and new lesions could possibly develop. Again, the median survival with whole brain radiation is about 4 to 6 months, and Prognostic Performance Scale, KPS, has a major implication for prognosis for all tumor sites. So what is the implication for practice? Many factors should be taken into consideration before recommending to proceed with whole brain radiation treatment. If you think back to one of the previous slides, 2.3 months is the same expected survival achieved with steroids only. So for patients in RPA class 3 or those who have a KPS of less than 70, there really is no expected survival benefit to adding whole brain radiation over steroids alone. And not only that, we would be adding toxicities of our treatment, which may significantly impact the quality of life for the duration of the person's life. Another treatment option is another type of radiation treatment, and it's called stereotactic radiosurgery. You may have heard of gamma knife, and it's the same type of treatment. So even though the word surgery is in there, it is a non-invasive procedure, and it's a type of radiation that delivers multiple convergent radiation beams to specific targeted lesions within the brain. The dose to these targeted lesions are much higher than what's given in whole brain radiation. It is a complex and highly technical procedure that requires many steps in coordination and treatment planning before the radiosurgery can be given. Patients must have a baseline MRI so that they can assess the number and the size and location of brain lesions. And in general, the criteria for stereotactic radiosurgery is if there are less than 3 lesions and they are all at, smaller than 3.5 centimeters, and where they are anatomically, they feel that they can tolerate a high dose of radiation. If lesions fall outside of these conditions, they still may be considered for SRS, and this will vary from center to center and vary from radiation oncologist to radiation oncologist. In terms of treatment planning, most stereotactic radiosurgery treatments are given with the use of a head frame that is attached to the individual skull with a few screws, and there's local anesthesia given before the screws are applied. So it's not painful per se, but the frame is fairly heavy. And this head frame is used for immobilization and then to ensure accurate targeting of the high-dose radiation beams. This is used for the planning scan, and then it is used to mobilize the patient as well for the actual treatment. And after the SRS treatment, usually on the same day that the frame is applied, so it usually takes about 4 to 6 hours on average to plan this. When everything is all done, the screws and the frame is removed. At some centers in North America, it's more frequently done without the use of a head frame, and it depends, of course, on the tumor location and patient factors, how well they're able to lie very, very still, those kinds of things. And in those cases without a head frame, they would make a mask instead, like the one with some whole brain radiation treatment. And then again, the mask is used for immobilization purposes. And then the radiation oncology team will plan the treatment, and typically the patient will return on another day for the stereotactic radiosurgery. There's level 1 evidence to suggest that a SRS boost given after whole brain radiation, if there are multiple lesions, improves local control, but not necessarily survival. Also, SRS given as an initial therapy instead of whole brain radiation treatment, if there's just a single metastasis and the patient has a very good KPS, this might be better for neurological outcomes and survival. However, in Canada, the common practice is still starting with whole brain radiation treatment, and then following that treatment with MRIs at regular intervals. And if lesions are growing or new lesions occur, then SRS may be given after that. And part of the reason for whole brain radiation treatment still being the standard treatment, it's dictated by the accessibility of technical resources, both in terms of we have limited access to MRIs in a timely fashion, and also not all centers have capability or expertise to do SRS. And so there's level 3 evidence to suggest that SRS alone has greater survival advantage than whole brain radiation alone if there are less than 3 lesions. And right now there is a large RTOG trial open. It's a phase 3 randomized trial in many U.S. centers, and also in Alberta at the Tom Baker, Hamilton, Toronto at PMH, and Sherbrooke, that is looking at offering SRS as the initial treatment, and then patients are randomized to either receiving whole brain radiation treatment or they may be randomized to just having surveillance with MRIs. And so there are studies right now looking at, is SRS the better initial treatment or whole brain radiation treatment, and in what scenarios? I'm not going to spend a lot of time talking about chemotherapy, other than to say that in the past it was thought to be completely ineffective due to the blood-brain barrier. But now we know that the blood-brain barrier is partially disrupted in brain mets, and so there is potentially a role for some chemotherapy or targeted agents. And how well they would respond to how effective they would be on a brain lesion would be similar to how effective the agent would have on their primary tumor. Unlike with primary brain tumors, combination of radiation treatment and chemo with temozolomide does not improve survival with brain metastases. And there are many studies in various stages looking at chemotherapy agents in a variety of cancer types. And so hopefully there will be some evidence arising soon that will inform more promising treatment options from a systemic treatment approach for brain metastases. And this is the last case that I wanted to share, and it's Sally. Sally is 73 years old. She was diagnosed with colon cancer about 5 years ago, and she did have surgery that resected the tumor, but when the surgeons advised that she should have chemotherapy as well to improve her survival outcomes, she made the decision at the time that she did not want to have chemotherapy. She felt it would have a real negative impact on her quality of life. And so she just thought she would take her chances and focus on living well over living longer. So that was 5 years ago. She presented suddenly with confusion and progressive fatigue and generalized weakness. And when she finally had her CT of the head done, it showed she had innumerable lesions in her brain. She was started on steroids, and it was 2 to 3 weeks on steroids, and she didn't really have any improvement of her confusion at all. So because she had impaired cognition, this obviously impacted her understanding of treatment discussions, and it would impact her capacity for consent. And ultimately, though whole brain radiation treatment was offered for this for Sally, the family opted against proceeding with radiation treatment, and what they wanted for her was supportive care alone. Again, trying to keep in line with her previous wishes of quality over quantity. So every individual's circumstances are unique, and the option of palliative and supportive care alone is sometimes chosen by patients and families, and is also sometimes the treatment option recommended by the healthcare team. As such, there's a huge role for palliative and supportive care experts in brain metastases to optimize function and quality of life. Expertise in symptom management is an essential component of care for people who have brain metastases, and there's many symptoms that can be common that will require concurrent and ongoing management. Additionally, care providers need to reinforce understanding of prognosis and expectations of treatment, provide clarity about the disease trajectory, assess and intervene for patient and caregiver distress, and early discussion of advanced care planning and goals of care is important, and a multidisciplinary team approach is essential for ongoing support. What does patient-family-centered care look like for these individuals? Well, throughout the patient's cancer journey, oncology and palliative care providers and the entire team need to be mindful of helping clarify the values and the goals of the patient and family, to, on an ongoing basis, advocate and promote shared decision-making, to be skilled in dialogue about reinforcing realistic expectations and goal setting, especially as disease progresses or health deteriorates. These individuals need help navigating our complex health systems and understanding our complex treatments and complex discussions about what options they have. We have a huge role of educating them, and also a responsibility to stay current on information and support resources. In conclusion, if I had to just tie it all together with a few points, I would say that treatment options for brain metastases are diverse, and they range from very high-tech invasive procedures to supportive care alone. Functional status and quality of life is impacted both by the brain metastases themselves as well as the treatment decisions and the treatment options that we give. And individuals need to be fully informed and engaged in decision making so they understand what the expectations of our treatment is. And surveillance and support for individuals is needed from the time of diagnosis through their treatment, should they opt for treatment, and right to the end of life. Thank you very much.
Thanks, Helen. Such a great presentation. Lots of really great information for everybody. It doesn't look like we actually have any questions right now. I'll give everybody just a moment, though, to see if there are any questions while we just wrap up here. And I'm just going to switch myself as presenter for a second so you can see my computer screen. I just wanted to let everybody know that we have our annual spring sprint coming up. Well, sorry, we're in the middle of our spring sprint program, and if you are in one of our spring sprint cities, you'll see the list here on our computer. You can go to www.springsprint.ca to register for your local spring sprint. We still have about another 8 or 10 spring sprints happening in the next couple of weekends. As well, we also have our Information Day conferences that are happening. So for those of you in the Halifax area, the Halifax Information Day will be on Saturday, June 8th. For Vancouver, it'll be Saturday, June 22nd. Calgary will have a full-day conference in Calgary on Saturday, September 28th. And for those of you in London here, Saturday, October 19th. And then for those of you in Saskatoon, we'll be having a half-day conference on October 26th as well. It looks like there is one question, Helen. So I'm just going to bring it up here for you.
Okay.
What is the difference between supportive care and palliative care?
That is a great question, and one that I think is almost impossible to answer, in that there's a lot of debate about that, you know, locally, and I think everyone who works in palliative care has a different opinion about that. But I think they to me, they mean essentially they overlap. So palliative care is, you know, expert health care by people who are trained in issues that people face when living with incurable disease. So whether it's symptom management, psychosocial support, care, you know, enlisting ancillary support services, all of that kind of expertise. And I think supportive care is perhaps even broader to include our other allied professionals within that. And so psychosocial services, social work, counseling, pharmacists, physio, rehab, all of that. That's my opinion, but I think that I would be interested to hear if other people feel differently.
That's great. Thanks, Helen. And I can follow up on that question for everybody as well via email. A couple more questions. One is, do symptoms of brain metastases differ from primary brain tumors?
They're very similar. If you look at the symptom list, they're probably identical. And I think sometimes it's really important or one of the things that the physicians have to tease out is when an individual has those symptoms and they present with an abnormal brain scan showing lesions. Is it metastatic lesions, or are they a primary tumor?
Great, thanks, Helen. And another comment from somebody, thank you for the presentation. I've learned so many tips of information. For example, the rationale for dexamethasone and versus prednisone. And we have another question here from somebody, but I think that it's probably best that we follow up via email because it's fairly specific surgery-related questions. So we may have to relay it to our professional advisory group or maybe one of your surgeons on staff there, Helen. So I'll follow up via email about that one. And so thank you very much to everybody for participating today and for taking the time to learn more about brain tumors and brain metastases. And thank you to you, Helen. Great presentation and lots of great information.
Great. Thanks, everybody.
Take care.